technical difficulties over here. Hope everybody can hear me okay. Can I get a response in the chat if you guys can hear me?
Yeah, I can hear you.
Excellent, thank you. Awesome. Well, it's good to be with you again. I am, for those of you who may have been out, I am Dr. Verona Navarrete. I'm a psychologist in the United States Air Force, and I've been prescribing now for the past 10 years. I'm also uh, I'm also a graduate of your current program. So my first time teaching this class was actually as a co-facilitator to my, or co-teacher to my supervisor, who, to the person who was supervising my practicum, who at the time was a graduate also of the psychology demonstration or psychopharmacology demonstration project of the Department of Defense. Trying to sort out how to, how to make sure I'm sharing my screen. So bear with me a moment. Okay, I think I got this, hopefully. And then I just need to move a few things out of the way. All right. Okay. So hope everybody had a good couple of weeks. And first of all, I do want to say that my apologies for posting the exam later than anticipated. I wasn't aware, to be frank with you, that the school's policy is to have the exam posted as soon as possible after the class. I now am, so I'm ready to post this exam. I'll be ready to post this exam tomorrow morning. In the meantime, I also want to let you know we will have, there should be some postings already on Moodle that are associated with this class. I will also post a study guide, and let's see, what else do I need to say? I know I owe you from the previous class postings regarding perimenopause, and I will have Aiden help me to add those before the end of today or tomorrow for sure as well. So with all of that in mind, we'll go ahead and get started. I just want to emphasize the ROEs, or the rules of engagement, as far as the class goes. If you could please make sure to unmute your microphone and stop at any time to ask me any questions. We can have discussion in the chat, but I promise I won't be able to keep up. So there may be times when I ask for responses in the chat, and I appreciate your participation. But other than that, like I said, I really like it if you could, speak to the microphone, ask your questions, and we'll make sure to move forward. We'll be taking breaks every hour, as we did last week or last couple of weeks. Also have some poll questions embedded in the lecture. This lecture is neither as dense nor as packed as the one that we had a couple of weeks ago. Certainly there could be more material added, but I think it's meant to be, and I think it does give you a great overview of ethnicity factors that you are going to impact your knowledge and practice of psychopharmacology. And I want to start off by saying that it's not all comprehensive. It can't be. So there's bound to be some errors of omission and errors of commission. There's bound to be some generalizations, and we'll talk more about that as we discuss the major ethnic groups in the United States. But again, it's meant to give you an overview, an outline for thinking about transcultural issues and prescribing. And like I said, it's not as packed as the lecture a couple of weeks ago. So hopefully we'll have some good time for discussion, and also cases that we can process this information through. All right, without further ado, if my computer decides to move forward, sharing the outline for today. We'll talk about the PEP knowledge domains real briefly. We talked about them last time, so we don't really need to spend a great deal of time on them. They're really just for your information only. We're going to talk about an overview of what transcultural psychology is intended to address. Discuss why it's important to learn this topic, what it means to be culturally competent, and then talk about specific topics such as transcultural psychopharmacology and genetics, including pharmacogenetics, environmental factors, genetic polymorphisms, phenotyping and genotyping. This area of genetics isn't intended to be a review. This should not be the first time, I hope, that you have heard this topics be mentioned. So we're not going to go in great depth. I will assume a level of knowledge, that you already have, that you should probably already have about this. Again, it's intended to be a review, but of course, if you have any questions, let me know. And then moving on, day 2. So tomorrow we'll be talking about culture-specific factors as they relate to the major ethnic populations in the United States. Again, realizing that it cannot be all comprehensive. But we'll be talking about Asian Americans, and specifically because they do tend to form a specific subset of Asian American population. We'll talk about Arabs and Middle Easterners, Latinos, African Americans, and Native Americans. And then we'll close by giving you some guidelines about what culturally competent psychopharmacology is, and endorse some ideas or thoughts about how to move forward. As before, I have to start by providing you a disclosure that what we talk about in the next couple of days are my opinions only, and they do not represent the Department of Defense of U.S. Air Force policy, unless of course, I'm referring specifically to U.S. Department of Defense or U.S. Air Force policy, which I will tell you about. Once again, not most, but 100% of my clinical practice has happened within the context of the DoD. And so there are some factors associated with that I cannot leave out of, the case examples and knowledge that I share with you. But I want to make sure to speak on my own behalf and not for the Air Force. Okay. So we'll go ahead and get started. Transcultural psychopharmacology, special populations, ethnicity, all those terms are things that you're going to hear me say throughout and at different times. Really what we mean is culturally competent practice of psychopharmacology. So I mentioned in the last class that there are specific areas of the psychopharmacology exam for psychologists that touch on the areas that are covered for this class, both gender and ethnicity, and I've highlighted some of the same content areas that you saw in the previous class. In this setting, highlighted in red how they relate to what we're going to be talking about here. Things like understanding biopsychosocial variables, including family history, patient belief systems, and culture, very specific, economics and poverty, social support, and current environmental circumstances. Things like knowledge and limitations and benefits, patient perceptions, including help-seeking attitudes and treatment expectations. In the next slide, as far as integrated psychopharmacology, they talk about knowledge of practitioner-patient partnership for case and medication management, including the impact of several factors such as ethnicity, culture, sexual orientation, gender identity, socioeconomic factors, religion, and refugee status. With regards to the nervous system, as it applies to this class, we're going to talk about somatic presentations and somatic complaints that may be comorbid or associated with psychiatric symptoms, especially in minority populations. We're going to talk about etiology and prevalence of drug-induced movement disorders as they relate to etiological factors, signs, symptoms, and diagnosis across the different ethnic groups. Um, we'll be talking about pathophysiology, as I mentioned before, talking a little bit about genetic polymorphisms and ethnic variations in the CYP450 enzyme systems. So we'll definitely be covering that, as well as different ethnic groups' reactions and metabolism of things like alcohol and alcoholism rates or prevalence. Um, and again, I won't belabor the point over and over again throughout the PEP. You will see questions that are interspersed and delve on the areas of gender and ethnicity as much as they are testing you on other areas of knowledge, including, in this case, biopsychosocial and pharmacological assessments, such as laboratory exams, um, and so on and so forth. Things that are important to highlight in this slide, the cultural impacts on dietary habits, family medical and psychiatric history, including knowledge of diversity-related variations in the incidence, prevalence of disorders, history of sexually transmitted diseases, and there are some ethnic differences as far as new rates of certain sexually transmitted diseases that we'll talk about. And then, of course, differential diagnosis. Um, and then I think that's pharmacology is the last one. And again, we'll be talking about pharmacokinetic differences in different populations and the different cytochrome P450 enzymes, as well as drug and drug food interactions, and some of those that may be a little bit more difficult to manage, perhaps based on dietary habits for different populations. Um, Okay, this is within individual differences, but again, even their ethnic factors are mentioned in the area of clinical psychopharmacology. Talks about genetics, ethnicity, cost is something that we haven't talked about, or likely you haven't talked about in other classes. Perhaps you have, as it relates to socioeconomic parameters that would make it difficult or easy, to prescribe certain types of medications to certain populations. Um, Again, more of the same. You'll find a common theme is, individual ethnic and cultural factors that play into all the areas of knowledge. And then finally, research, as we mentioned before, we have um, not done a great job of incorporating diversity variables. When they are used, they could be misleading or perhaps even mistaken or misguided. And so, we have to assume that some of the knowledge that we have acquired in other classes so far are based on samples that could potentially not be representative of, what the typical, what our typical client populations may be, or even what the US population may represent. All right. Um, for the sake of avoiding repetition, I'm going to skip this slide 21 and 22. Again, we've talked about some of those before. So once again, I just want to close by saying, the reason that we take this class is because we do consider this issues to be prevalent and important to the rest of your knowledge in psychopharmacology. Okay, so what is ethnopsychopharmacology or transcultural psychopharmacology, TP or EP, which is how we're going to relate to it within the next couple of days. This is one definition from, let's see, Ming Lin, and psychological ethnopsychopharmacology advances in current practice. Um, And that is the study that attempts to answer how culture and genetic differences of natural social groupings of the human race determine and influence response to psychotropic medication. Seems very simple and straightforward. So that's the reason that I'm using this definition. um, to go a little bit further into it, we have to, consider variations in pharmacokinetics, pharmacodynamics, and cultural influences in the responses of drugs to drugs among various ethnic groups. Um, and and again, consider intra and interpersonal differences as well. So, why are there obstacles to being competent from an ethno-psychopharmacological or transcultural psychopharmacological perspective? I think some of the primary obstacles is that we relied very frequently and very for a very long time in clinician anecdotal reports of information that gets passed down from supervisor to supervisee or preceptor to preceptee, et cetera, where it says, oh, my experience with this population, my experience with this group, tells me this. And, it's obviously based on anecdotal reports and based on broad, potentially overgeneralizations about a group of people based on very, very small samples. As I mentioned before, one research limitation that we have is that there are very few vigorously designed studies. And there's also controversy about how studies should be designed in order to be able to truly incorporate ethno-psychopharmacological factors. And, we'll talk more about that in a few slides. There's often conflicting results, and you will see, a little bit of this in what I present to you as we talk about the different ethnic groups tomorrow. In some studies, some responses are observed, for example, for Asian Americans in SSRIs, and other examples or in other studies, a totally different response, may be observed. And so it's often up to the clinician to try to, make up their minds as to, what evidence, what areas of information to use, because there could be potentially some very broad, very interesting, conflicting results that we have to process through. And of course, there's economic and marketing influences and pressures. And so there may be the desire, especially from marketing, from pharmaceutical companies, to market a drug or a specific treatment for as many people as possible without having the evidence to back up that it could be beneficial for members of a different ethnic group, or for folks who have genetic or other characteristics that may make it where it may make it difficult for those drugs or those treatments to be effective. Um, so I thought it important to start by, coming up or talking about some definitions that are generally associated with the study of ethno-psychology or ethno-psychopharmacology. One beginning, or to begin with, the term race. It's been meant to describe a distinct population sharing physical, genetic, and social characteristics. But in reality, from a truly biological perspective, it really is nothing more than a sociopolitical term or construct. Yeah, people with share physical and genetic characteristics aren't necessarily always of the same race. And in fact, as you could see from my quote below, according to the Human Genome Project, people are indeed well over 99% identical. At the molecular level, race is imperceptible, which means that once again, the sharing of physical and generic characteristics, that does not necessarily mean in from a physical appearance perspective, that individuals are going to be as genetically similar as perhaps they would be with somebody of a different quote unquote race. Um, So, for example, it's important to point out that while researchers, and this ties back to the limitations of research, is that researchers will use words like race, ethnicity, and culture almost synonymously as they separate the samples in their studies, even though they have quite distinct meanings. Um, and also, as I mentioned before, because the terms are used interchangeably, and because they rely on a sociopolitical term or construct as opposed to a genetic underlying similarity, then a lot of studies have separated subjects in terms of race based on the person's own definition of their race. So if I say I'm Black, then I'm going to be classified as Black in the study. If I say I'm Latino, then I'll be classified as such. But in reality, the biological, said to be biological underpinnings of those classifications are very rarely put to the test. Per se, when studies do separate women by do separate subjects by their race. Um, okay, so enough of that. I'm actually, before I move on, I do want to point out that one of the readings that I've assigned to you, just for reference, is not anything that you're going to be tested on, but it should be in Moodle, is about the use of race in research, the term race and the qualifications of race. So if you want to read more about this subject, I really encourage you to. It's a very short read. I think it's a 1 page or 2 page at the most paper that would definitely give you a good or a better understanding of what I mean by this. So I'll get off my soapbox. Okay. Ethnicity, as I said, commonly used interchangeably with the word race, not the same thing. Ethnicity refers to social groups with shared identity, history, and cultural roots. And there's a significant variation of ethnicity with regards to country of origin and adherence to customs, meaning people with the same country of origin may have different levels of adherence to different customs, and therefore may not be able to you may not be able to make broad generalizations about them because again their adherence to customs may be quite different. For example, from a genetic perspective, Latinos are considered an ethnicity, and yet they could trace their origin to African American, European, African, I should say, European. Um, and Native American ancestry, to say the least, and depending on what areas of Latin America we're talking about, they may also have Middle Eastern, Arab, and Asian um, uh, ancestry. And so, while ethnicity is a much more, let's call it fuzzy in general, as I mentioned before, it refers to a social group that has a shared history, identity, and cultural roots. And it's really interesting to understand that ethnicity is, in many ways, self-defined as well. I share with people I had this experience after I got my bachelor's degree. I used to work in South Florida, as you know, the retirement capital of the United States. And my job was to be a case manager for the elderly population in the county. Many times when I would talk to individuals in terms of establishing demographic information, I would ask them about their ethnicity, and many times their answer would be something like Jewish, or some other sort of religion type of identity that normally, whatever normal means, that probably the majority of the outsiders from that group would not classify as a source of shared identity, or as a as an ethnicity factor. But if you look at this definition with regards to having a shared history, identity, and cultural roots, it most definitely, can be, the Jewish religion or the Muslim religion, and many others can be characterized as an ethnicity identity or ethnic identity. Culture, on the other hand, not again, somewhat similar and overlapping, but not entirely, refers to shared patterns of belief, feeling, and knowledge, and it's is rooted in um, uh, behavioralism in general. Behavioral patterns, things that you could see, including lifestyle that is shared by a group of people that distinguish it from other groups. Again, culture is characterized by a set of beliefs, values, and attitudes. In medical settings, you have to understand that there are three types of cultures that are present, including the culture of the patient, the culture of the provider, and the medical culture in which the care is given. So there's cultures that are not necessarily associated with race or ethnic factors. There are certainly cultures associated with, a shared pattern of belief of a group or a system. So, just to give you an example, in military, we understand there is a military culture, but further than that, we also have subsets of cultures among the military culture, including the Air Force culture, the Army culture, the Marine culture, and again, more specifically, units and localities of those cultures that are very different from one another. For example, special operations or special forces in and of itself could be as a culture versus other cultures. Um, I'm getting a little bit of background. Did somebody have a question? Okay. All right. Okay, so things that we want to know as they relate to culture, ethnicity, and again, we're gonna, for the time being, hopefully put the word race aside. Are things like the incidence or prevalence of disorders that are associated with different groups of individuals, their help-seeking patterns, the difference in how they present with symptoms. Are they psychologically minded? Are they more likely to present with somatic complaints? Do they believe in, psychological health? Do they believe in, mental illness versus, some other form or etiology, for their disorders? We're going to talk about genetic predispositions that result in differences in drug metabolism and clearance. Other factors to know about are psychosocial factors and drug effects and response. And of course, we need to know about what is culturally relevant assessment and treatment. So why learned about this? And let's not say just for the PEP, because that is not the right answer. We're not just learning for the test, of course. We want to learn because we want to be competent and ethical psychopharmacologists. But more broadly, we need to learn this because, as you all know, as you're all aware, unless you've been hiding under a rock for the last 20 years, the United States demographics are rapidly changing, and there are many reasons for those changes, including low birth rates of the European population or Caucasian population, lower mean ages and increasing birth rates in non-European minority group, and different rates at different times, but for sure, immigration from Latin America, Asia, and Africa, and to a much lesser degree, new immigration from European countries. So just to give you an overview of what we mean by this changing population, I'm going to give you a little bit of a historical background. We're going to talk about, distributions in population as well as access to healthcare, because at the end of the day, part of the reason that we're talking about this is because there have been healthcare disparities in that affect, the different minority populations that live in this country, and that's part of the reason that that we need to address them separately in this class. So as you can see, total US population in 2010, you all know that we're due for a census in 2020. So the numbers are very much likely to be drastically changed in trending in the direction that I mentioned before, having larger numbers combined of minority populations. But as you can see, 64% of the population in 2010 was considered to be white, non-Hispanic, with 36%, roughly, math and public, of minorities in the mix. So about a third versus two-third would be the demographic. I'm sorry, the demographic um, uh, uh, breakup or breakout of the population in the United States. Interestingly enough, if you see here on top, two or more races, only 2%. I just want to emphasize that in the census, like everything else, because race is a sociopolitical construct, the ability to for people to self-describe as members of a particular quote unquote race or ethnicity is based on the availability of that descriptor on the census form. And so, you know, for many, many years, the number was limited for many decades, I should say. The choices were limited, and as we broaden some of those, you know, characterizations and definitions, and given the people the opportunity to endorse being a members of more than one race and or other, then obviously we are getting somewhat different results. You know, if you look at projections, so this were projections based on the 2010 census, which, you know, are deemed to be accurate still as of today. 60, as I mentioned before, roughly 65% of the population was a white non-Hispanic in 2010. 46% is expected to be white non-Hispanic, so the minority of the population will be white in 2050, with 30% defined as Hispanic, 12% Black non-Hispanic, 8% Asian, and 4% other. The largest growing number, as you can see from this breakout, is the Hispanic population or Latino population. And by the way, I didn't choose the word Hispanic. The U.S. Census did. It's a word that was originally created by the U.S. government for the purpose of the U.S. Census, so that's why it's listed as such. So I want to go backwards in time because I want you to see how the importance or the need for us to be competent in this, or culturally competent, has shifted over time, has changed over time. Which, you know, may explain the scarcity of knowledge that we have about some of these things. So this is a breakdown of the population in 2000, and you've already seen what it was in 2010, what is projected to be in 2070. I'm sorry, 2050. And just, you know, in 2000, 69%, so close to 70% of the population was white non-Latino, with African Americans and Latinos about equally represented at 12.1 and 12.5%. And again, you know, less categories available for us to break down people who belong to other ethnic groups. And just to bring it back, you know, here's the significant shift over time, with Hispanics growing to 16% in just a decade, Asians growing to 5% of the population in just a decade, and again, likely other populations increasing at variable rates. Going back a little even further, look at this, you know, 1980 versus 1990. The 1980 is the green bars, 1990 the blue bars. So again, 1980, 83% of the population was white. 1990, 80% of the population was white. So it's been rapid, by some estimations, very rapid changes in the population, and certainly um, a um, call for the need for additional information about this populations. I just noticed I don't think I had um, I don't think I had noticed before that there is no line for Hispanic population in this chart. And I am not sure if they were classified under the other or, why that is. Okay. Um, and the population, so not only is the population changing, but the population is changing all over, quote unquote, or mostly. As you can see, the states with the larger numbers of minority individuals or persons of color are on both coasts, the East Coast and the West Coast and the South, primarily. Some of the Midwestern states like Minnesota, Illinois, and Nebraska have growing numbers, Michigan as well have growing numbers of persons of color or minority populations, but less so, as you can see in some of the other Midwestern states like Montana, Wyoming, North Dakota, and South Dakota. So, if you, again, additional information about where those population changes are happening. So let's talk a little bit about who works and as far as work and income among this population, because these are important socioeconomic factors that will affect access to care and, again, health disparities, as well as the provision of medical and mental health services to different populations. As you could see, lower rates of full-time work in Black or African Americans and American Indians compares to white, Asian, and Hispanic. As far as blue collar workers, overrepresented by Hispanic, Black, and American Indian population, and family income below poverty, once again overrepresented by Hispanic, Black, and American Indian populations. Again, so important factors as we talk about socioeconomic status and its impact on health disparities. We do know, and this is an old quote, but I do want to emphasize that this is likely as true today as it was in the past. There's been a commission on health disparities that has had set targeted goals for 2010, which were not met. And the targeted goals were then moved to 2020, and I can honestly say that they're likely not to have been met. And so this continues to be true today as it was in 2003. There are racial and ethnic disparities in healthcare, no question about it. And they're remarkably consistent across a range of illnesses and healthcare services. So private versus government funded or community-based, insurance versus non-insured, or private insurance versus government insurance, such as Medicare and Medicaid, et cetera, et cetera. There just simply is, or there have been a lot of evidence for health disparities across the U.S. And according to the Institute of Medicine, as you see there, providers may miss screening because they are unfamiliar with the prevalence of a condition among racial or ethnic groups. They may fail to consider differential responses to medications. I don't know the numbers, but I will tell you that I am still surprised in 2020 to see how many medical residents come into residency without any prior knowledge, prior study of cultural or ethnic factors as they relate to access to healthcare or healthcare help-seeking factors. And I don't know if anybody in the audience has worked with, medical students or in training medical residents or anything like that, but there's still a lot of gaps in knowledge which I think our field has been way ahead of many other healthcare professions in terms of integrating knowledge about ethnic and cultural factors as they um, relate to the healthcare, to mental health specifically, but in general healthcare. In fact, one of our previous students in the class has been working in the Ohio legislature to be able to establish prescribing rights here in Ohio, which I have been, happy to support and to, hope to be able to come, bring to fruition with the of course, with the lead of the OPA. And one of the bills that the OPA also supported and gave inputs to the legislature on was one that would dictate the need for physicians to have continuing medical education, not every year, but every so often, as it related to ethnic or cultural factors associated with healthcare. And you would not believe, or maybe you would, the amount of opposition received from the medical community about having such a mandate. Um, So just important to point out, as I mentioned, that providers may order fewer diagnostic tests for patients of different cultural backgrounds because they may not understand or believe the patient's descriptions of symptoms, language barriers, communication barriers, or simply, the native quote unquote explanations of symptoms for a population or an individual that may not be as, Western healthcare minded as the doctor may be. Conversely, providers may order more diagnostic tests, making the cost of healthcare more expensive and potentially difficult for the patient to manage and afford, to compensate for not understanding what their patients are saying. There may be potential harmful interactions between prescriptions and traditional remedies used by the patient that may be overlooked. I don't know about some of the settings that you practice in, but I do wonder, how often doctors, and when I say doctors, I mean physicians in primary care primarily, or some other specialty clinics are asking their patients about the types of traditional remedies or practices that they have engaged in as a means to treat their conditions before they come in to see them, or whilst they're also seeking health care. Excuse me. Miscommunication may lead to faulty diagnosis, unnecessary lab testing, medication-related errors, decreased treatment adherence, missed opportunities for early detection and prevention. And we do see that translated to higher death rates, for example, in some cancers, lower detection rates of, some really preventable diseases for some populations. And so this is really critically important. Did you know, for example, that providers are more likely to prescribe older medications for more serious mental illness to minority groups? Yes, you learned it. You probably learned it in graduate school. It's as true today as it was, 20, 40 years ago, that, Blacks or African Americans were more likely to get traditional neuroleptics then second generation antipsychotics, and even tricyclics, as opposed to serotonin specific reuptake inhibitors. Much less likely, I think, in the in the current healthcare systems, especially with expansions in health coverage in the recent past, but still, it does still happen. Um, so, for example, this 2009 New York Times article highlighted this Rutgers Columbia study that found that poor children were more likely to get antipsychotics prescribed to them, and this was, as tied to federal finance, uh, 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 insurance such as Medicaid. And you can see for yourself, prescriptions of powerful antipsychotic medicines at a rate for 4 times higher than children whose parents had private insurance. something to be said about that. There's probably a lot of factors associated with that over, prescription, but that, like I've said before, it's a true highlighting of a medical disparity. Um, Also, highlighted in the article, Medicaid children are more likely to receive the drugs for less severe conditions than their middle class counterparts. So, why would that be? Some possible reasons that were listed in the article are that Medicaid often pays much less for therapy than private insurance, and so private insurers. So, from a reimbursement perspective, there's or from an access perspective, even there may be more difficulty for parents to be able to seek psychotherapy services for their children who have ADHD or other, less um, severe conditions that would not typically require treatment with antipsychotics, but because they don't have the time or the money or the access, they may opt to, they may be not the parents necessarily, but the system itself may be opting to over medicate these kids. Um, Again, families in poverty may experience more difficulty attending therapy sessions. There are separate but unequal sources of care. Children of lower SES and below the poverty, living below the poverty line are much more likely to be seen in primary care versus seeing a specialist, resulting in unmet needs and potentially misdiagnosis and over prescribing. Provider misdiagnosis and bias may be a factor. Is a minority child with ADHD more disruptive, potentially to an already strained household or an already strained educational environment or social environment compared to a middle class child who, may have, access to better educational supports and educational needs, and whose parents have a higher tolerance for such behavior. Provider, let's see, misdiagnosis and bias or unwillingness to use drugs off-label. The example I use, antipsychotics for ADHD. Believe me, there is no antipsychotic medication that has an FDA approval for ADHD. And of course, there's just a mere fact that minority status may result in greater stressors and therefore greater mental illness. But so just some things to think about. I think, yeah. We're going to start, as we talk about socioeconomic and other factors, we're going to start talking about insurance coverage and some, so historical and current trends as they relate to minority populations. So before we do that, let's go ahead and take our first break. Does anybody have any questions before we break? All right, Carmen, thank you for sharing the prep review material. And with that, I got 52 minutes after the hour. I'll go ahead and see you 10 minutes from now. Okay. As I said, we're going to start talking about insurance coverage and thinking about how that affects access to care and other issues associated with healthcare in minority populations. So as you can see, this was insurance coverage of the non-elderly population by race and ethnicity, another census figure. Actually, this is from the Kaiser Family Foundation. Um, the reason that is broken down by elderly versus non-elderly, of course, is because elderly qualify for Medicare. And so in ideal circumstances, 100% of them should have some sort of medical coverage or insurance coverage. As you could see, 71% of whites had employer or private practice or private insurance, sorry, 15% Medicaid or other public insurance, and only 13% were uninsured in 2011. This is before the Affordable Care Act, so we'll keep in mind that things have shifted, and those shifts have been more significant for the minority populations, especially where Medicaid expansion has taken hold. But hold that thought for a moment. Similar rates of insurance and private versus government versus uninsured in Asian populations. But as you could see for the three populations at the bottom of the graph, Hispanics, Blacks, and American Indians, a very different picture with more or similar rates of government insurance and uninsured in Hispanics, about a third each, and American Indians similarly, and less comparatively to Asians and whites, rates of employer or private insurance. Let's see. Obviously, the lack of health insurance affects an individual's ability to obtain care and has consequences for health and financial well-being. As you guys know, lots of economic problems associated with unmet healthcare needs or unforeseen, unforecasted healthcare needs for the poor in this country. And once another thing that is important to highlight is that Medicaid is an especially important source of coverage for people of color, providing coverage for at least 1 in 5 of the non-elderly population. And this is a newer graph from 2014. Again, numbers for Asians and white remain pretty stable, with lower numbers of uninsured that we saw, just 3 years before. So this is after, again, 2011. We got 13 and 18% uninsured in the white and Asian populations, respectively. This is after ACA. We had 9 and 10%. Of those populations uninsured. Lesser numbers overall of uninsured in the other categories, including Hispanics, Blacks, Asian, and NHOPI. Sorry, and it was listed there. Native Hawaiians and other Pacific Islanders, which was an additional breakdown that we didn't have in the previous graph. So still significant numbers of minority populations are using government insurance, but as you could see, a significant decrease in the numbers of uninsured. This is another way to look at it, with the additional breakdown of children who were covered by private versus government insurance versus uninsured in 2011 compared to adults. And the total uninsured rate by race and ethnicity, again, much more likely, at least 55% of minorities, 55% of the uninsured, rather, were members of a minority population. And again, this is a change over time. In 2014, total population of color was still 55%, represented 55% of the uninsured. The rates, as you saw before, had shifted a little bit. So this is a more recent breakdown. I don't know how well you could see it. Let me see if I can enlarge. Yes, there you go. That's probably better. And between these are rates, reported by Health and Human Services, so government report that demonstrates shifts between 2017 and 2018. The percentage of people who were uninsured by age, 19 to 25-year-olds representing the largest group, followed by 26 to 34-year-olds. So you could see that, this is prime time for employment, prime time for employment benefits, including insurance, but really, a significant number, 14% of 19 to 25-year-olds, and and another 14%, or close to 14%, of 26 to 34-year-olds remain uninsured. Then you could see the rest for yourselves. As far as, I need to bring down the size a little bit, percentage of children under the age of 19 without health insurance, again, some over time. Let me go back so you could see what those numbers were in 2011. So you could see 16% of Hispanics, 11% of Blacks, 17% of American Indians, and children, the population of minors, were uninsured. The rates in 2018 have it so that, let's see, Hispanic of any race, 8.7% are uninsured. Black, 4.6%, Asian, 4.1%, and 7.8% of children who live under the poverty line are uninsured as of 2018. And this is another interesting graph. This breaks it down by poverty status and Medicaid expansion. And again, I just want to highlight how, based on the numbers that we saw in previous graphs, Medicaid and government-funded insurance is a significant contributor to insurance in the minority population. So that those expansion states were able to increase access to insurance coverage for many, many more minorities compared to non-expansion states. And you can see this for yourselves with, let's see, the darker blue is 2018, between 100 and 399%, or, let's go with the first graph, 35.6% of people below 100% of the poverty rate were uninsured, compared to expansion states where only 16.9% of below 100% of poverty guidelines were uninsured. So it wasn't a complete wipeout in terms of uninsured rates, but significant differences, 16.9 versus 35.6 in expansion versus non-expansion states. So once again, just want to highlight in terms of access, in terms of disparities, those who are more vulnerable, and where they are more vulnerable, it's something that you guys should think about depending on where you practice. This map represents uninsured rates by state, with the darker colors representing higher numbers, of course. You can see Texas, Oklahoma, Mississippi, Georgia, and Florida have a 12% or more uninsured rate. And a circle indicates, let's see, those states that expanded Medicaid before January 2018. So lower rates of uninsurance in general, although there are still significant problems in places like Nevada, Arizona, New Mexico, but a lower in general uninsured rates in states that did adopt the Medicaid expansion. Okay. Those are historical trends. I don't think we need to focus on those as much anymore. But the key overall a finding that I want to highlight is that per the Kaiser Family Foundation, uh, which is where a lot of this data is coming from, not all, as I mentioned before, there are some key issues associated with the uninsured. First of all, reflecting their limited incomes and lack of access to employer-sponsored health insurance, people of color are more likely to be uninsured than whites. We already talked about that. The ACA coverage expansion significantly increased coverage for people of color and reduced disparities in coverage. And then, again, we can see that by the numbers. I'm not here to make any kind of political arguments whatsoever. We're just showing you what the numbers would indicate. And that people of color have particularly high stakes in state decisions to implement the ACA Medicaid expansion, and that's per the Kaiser Family Foundation. And again, these numbers, I want to highlight that these numbers contrast the expansion versus non-expansion states come from the Department of Health and Human Services, not from a private organization. Okay. So we're going to move on to talk about cultural competence and what it means. But before we do that, we have our first poll of the morning. Just want to make sure that everybody's still up and has their coffees, paying attention. So Aiden, would you mind posting the first poll? Okay. So I think most of you have polled already. We're going to go ahead and end it and then share the results. So as you can see, the review of slide, what would this be? Goodness, sorry, I lost it. 31. Because of the 2010 US Census reveals shifting population trends so that by the year 2050, or a future projection, the majority of the US population will be people of color. 16 of you, or 76%, had the correct answers. Um, Not sure if if C would be true, that Asians are more likely to be in the over 65 years of age category than any other group. We just didn't talk about that, and it's not data that we have. But we do know that the European population has had lower birth rates and is projected to have lower birth rates. Um, So we will have a majority minority population in 2050 by all projections, as you can see there. Um, all right. So let's go back. We were in slide 55. Okay. Oh, sorry, I'm moving. Just trying to move things along the way. Okay, there we go. All right, so let's talk about some context or yes, some factors or definitions that have to do with cultural sensitivity or cultural competence, rather. So first things that you may have heard before, likely have heard before, and I don't contend to be an expert in this matter. It's just an area of interest, but I want to make sure that you're aware of it. Cultural sensitivity, as defined there, means that differences exist. You understand that differences exist and wanting to learn more about them without stereotyping. It means really a willingness to explore and learn from patients and their families about their beliefs, attitudes, value systems, and ways of dealing with problems, but not just to learn from your patients, but also learn from the research and the media, the historical books, and other areas of knowledge to increase your sensitivity to areas of differences between you and your patients. Cultural knowledge describes the basic anthropological information such as epidemiology, illness behaviors, culture-related syndromes. Some material that we're going to cover in this class. And it's important to highlight that besides books, articles, we can also use consultations with experts on a particular cultural system, such as some of our own American Psychological Association or other professional organization divisions or task forces that have addressed particular cultural groups. And can use patient and family or friend of the same ethnic or cultural background, again, with the caveat that we may not necessarily be able to generalize from one individual to another. Uh, Cultural empathy talks about the ability to feel and understand the patient's cultural perspective. So, having a curious attitude, being able to listen, excuse me, listen for those areas of their, psychological distress or presentation or biopsychosocial environment that are representing areas of cultural that cultural beliefs or knowledge that would be really important. And one of the newest terms, which is not listed on this slide, newest as in, probably within the last decade, is that of cultural humility. And that is, our defined or expected to be our approach to the realization that we don't have all the knowledge, that there's an ever changing there's ever changing information about cultures and individuals as particular members of their culture, but approaching our lack of knowledge with sensitivity, empathy, and humility goes a long way towards making sure that we are engaging in culturally appropriate and competent interactions with our patients. Um, Other terms that may be associated with clinical cultural competence include culturally relevant interactions and relevant therapies. So, for example, interactions talks about the ability to trans, detect or manage, and/or manage, I should say, transference and countertransference based on differences in backgrounds. Whereas culturally relevant therapies is talking about the most effective interventions, which of course will consider the role of cultural factors on illness. So, for one example, would be, to the question of do you hear voices, understanding the cultural systems in which, or the culture, the belief systems in which some individuals from specific cultures may actually not, may have a non-pathological uh, um, belief that they can hear voices, that they can communicate with their dead, for example, their ancestors, or their natural environment in a way that would not be considered a mental illness per se. And then it also talks about culturally sanctioned coping mechanisms that are reinforced and or that should be confronted potentially because they could be counterproductive. And walking that definitely sensitive line between reinforcement and confrontation, or just simply acknowledgement versus confrontation. We're going to talk about, as we talk about the major ethnic groups, culturally related syndrome. And I just want to highlight this was a change between DSM-4 and DSM-5, that we used to call this culturally bound syndromes as a way to indicate that they were particularly more prevalent in one population versus another. But more and more with A, globalization, and B, additional knowledge and information about how some of these things may cross lines or may cross different cultures. We're going to talk about cultural related versus culturally bound syndromes. Um, okay, so it's really critical, and again, probably self-explanatory that it is that cultural competence is important because the understanding of the patient's illness, their perception and presentation of symptoms, the reaction and adjustment to their illness, from being disheartened versus being upset versus being accepting, and the expectations of the provider, the desire or expectations and adherence to treatment, their motivation to engage in treatment, I've already mentioned adherence, and the clinician diagnosis and choice of treatment are all influenced by culture. Um, so, of course, cultural competence is a way for us to improve our understanding of the patient and the clinical outcome. And, one example is the old order Amish and bipolar symptoms, the understanding of Chinese and depression versus neurasthenia, and as I mentioned before, cultural related specific syndromes. And if you don't, if you're not familiar with the Amish or the cultural factors associated with the presentation of bipolar in the Amish community. Um, Interestingly, while the rates of bipolar disorder are not any different in the Amish community, their rates of recovery and the actual presentation, their assumptions and beliefs about the illness make it so that the prognosis, from a prognosis perspective and clinical outcome perspective, the illness, they seek medical care, and they view it as a medical illness, and the outcomes are much more positive than you would see in other populations. And this is true of many other conditions. By the way, my dissertation way back when was in part related to looking at the outcome of chronic and severe mental illness among different populations. And one major finding of my literature review and some of my study is that the outcome, the functional outcomes, not clinical, but the functional outcomes in for patients with severe mental illness that are reared or live in collectivistic societies far outweigh or far are a far improvement from those who live in an individualistic society such as ours. Um, okay, so yet another, we have a couple of other polls to do at this time. Let's go ahead and get those started before we start talking about genetics. All right, we just finished our 2 minutes, so let me go ahead and end the poll. I think I have most of you participated. And all of you who answer at 100% correct. So let me share the results. We got the first question. Again, just try to make sure that you guys are integrating new knowledge and paying attention. Since a significant portion or proportion of pharmacological research has been performed on white male subjects, the reasons that transcultural or ethnopsychopharmacology is important for the clinician is that culture affects all of the above desired and expectations of treatment, expectations of the provider, and perception and presentation of symptoms, all which we talked about as significantly impacted by cultural beliefs and behaviors. And second, which kind of follows, culture could be defined as a unique behavior pattern or the unique behavior patterns and lifestyle shared by a group of people that distinguish it from other groups, which is also true. And 100% of you who participated got the correct answer. So, congratulations. And let's move this out of the way. Okay, sounds good. Here we go. All right. So we're going to move on to talk about genetics, the most fun part of the class for sure. Maybe not. For some of you, once again, for all of you, this should be a review, hopefully presented in a way that makes it more understandable, more digestible. And if not, repetition can never hurt. So, it's just a good framework in order for us to be able to start delving into again, genetic differences that may impact psychopharmacological treatment. Uh, so this is a good graph from Chen, 2008, that could help us understand a pharmacological in general, but more specific to our topic, psychopharmacological response. So if you look at it, follow the graph from top to bottom, we have culture affecting environmental factors. ethnicity affecting genetics, those environmental factors also affecting genetics, and that forks into pharmacokinetic and pharmacodynamic, and the interrelationship between dosage and side effects, as well as clinical response based on those two factors. So, needless to say, this will help us understand that drug efficacy and toxicity is going to vary across individuals. It could also vary across groups of individuals. Factors that affect drug metabolism for certain drugs should be considered when dosing regimens are established. And some of those include genetic polymorphisms that might influence drug plasma concentration, therapeutic drug response, side effects, et cetera, et cetera. Um, the other factor that Chen advises that we consider is ethnic differences in the prevalence of obesity, which would impact the concentration of lipophilic drugs. So really critical information when it comes to the specific or the particular individual that you have in front of you. So remember this, you should remember this. I hope we talked about it in the last class. I find it a very useful tool for understanding, if we go back to the previous slide, that interaction between environmental factors and genetics, and what you see here is in those bidirectional lines, how genetic constitution both influences the manifestation of stress, but it's also influenced by stress. It's also influenced by starvation, behavior, alcohol intake, tobacco or marijuana or any other substance use. Um, Things like exercise, sunlight, sunlight and exposure to sunlight that might vary not just across ethnic groups, for example, Northern Europeans versus South Africans, but how they might manifest in a specific individual who may move, from Africa, for example, to a northern um, country, a northern climate, et cetera, et cetera. So once again, I just want to make sure to emphasize this relationship between our genetic constitution and environmental environment. So there's this field called pharmacogenomics that seeks to understand or individualize medicine by using person-specific genetic information. And you might be wondering, what is that? What is that you're looking at in that picture? Before we move forward, does anybody know what you're looking at? Good guess. They're not ovaries or testes. Aliens. Yeah, they kind of look like. Okay. Good guesses. They're actually an organism known as water fleas. And I don't, they obviously have a scientific name, but they don't, I don't know the scientific name. I just use this as a way. I learned it from my supervisor, and I find it a very valuable way to help people understand that interaction, that bidirectional interaction between genetics and environment. So I'm going to tell you a little story about how I present this, to patients and, and to students as a way to understand, to highlight their understanding. So this set of individuals or individual organisms who I mentioned are water fleas have very interesting characteristics in that they are, as you could see, translucent, right? We could see their internal organs, if that's what you would call those tentacles that you see inside their bodies. And not only are they translucent, but they actually change colors based on environmental circumstances. So they turn red under stress, which is something that you see humans do sometimes. And so they're interesting organisms to study. What's even more interesting about this set of water fleas is that they are clones. So at this point in the lecture, you guys are probably wondering what they're clones. What we would expect to see from cloned organisms is that they are identical. of course, because genetically, clones are identical copies of each other, or, an identical copy of one organism is their clone. So you could see for yourselves as individuals, these organisms are not identical, and in the ways that they differ are very pronounced. So if you look up here in this area, the the top of the screen, the individual on the left, the organism on the left, has a very pronounced what we call helmet, whereas the individual on the right, the organism on the right, has a very well-rounded, not as pronounced helmet. And at the bottom of the screen, we see that the organism on the left has a very long and sharp spear, whereas it's called spear, whereas the flea on the right has a short and much less pronounced spear. So, from the perspective of genetic identity, genetic predisposition, and with the understanding that these individuals are clones, what, if anything, could account for their significant differences in genetic expression? Carmen says environment. Say more. Exposure to something like toxins. Any other thoughts? Stress, food source, diet, scarcity of food, lack of food. Yes. Temperature, lack of access to medical. Good, good one. Okay. Yeah, you guys are on the right track. There's a lot of environmental factors, as we mentioned in our previous graph, that could potentially create this kind of presentation. And Janelle finished off by saying abuse or neglect. And this is actually the primary way that I use to show patients and students, again, about um, transgenerational stress, is that the differences that account for this prolonged spear and prolonged helmet and prolonged spear with the flea on the left is that this one was reared in water with enemies or predators. So as a result of that, stress, environmental stress, likely a scarcity of food, a likely need to defend itself. It promoted the genetic development, or the genetic manifestations that we see are very different from its clone sister or brother. And so, again, that's just a neat way, I think, to show how different individuals, based on genetic, same or similar genetic predisposition, can have different manifestations of their genetic predisposition based on their environment. So pharmacogenetics is, as I mentioned before, a field that has sought and is seeking to individualize medicine by using person-to-person specific or person-specific genetic information. Because you better believe that this organisms, and let's think twin studies, let's think brothers, sisters, that or families that share biological background, are going to present very differently depending on their socio-environmental influences. And there's two branches of pharmacogenetics that are important for us to distinguish. So this is an important point that I want to highlight. Efficacy pharmacogenetics refers to the prediction of a response to therapy as influenced by genetic variation, whereas safety pharmacogenetics is concerned with the influence of genetic variation on drug side effects. So which one do you think is and by I mean, which one, efficacy or safety, which one do you think is trying to be targeted or is being targeted by the genetic testing that is being done for predicting or helping patients predict their response to a psychotherapeutic drug? Okay. I'm glad we have some different views. Eddie said safety. Eddie Taylor said safety. Carmen said efficacy. Eddie said efficacy. Kirsten said efficacy. So it's a trick question because it's both, and you'll see that. But not all of the uh, of pharmacogenetic treatments that we see these days are actually targeting both. Some, and I should say some of the genetic testing is targeting both. That would be the ideal circumstance, but it isn't always the case. So one example of safety pharmacogenomics is the recommendation by the FDA that that Asians, and particularly Han Chinese, should be genetically tested for the presence of an allele, a specific allele that we're going to talk about tomorrow, if the treatment with carbamazepine is being considered. And the reason for that recommendation, and it's actually more of a dictate or mandate by the FDA, is that people that have that specific allele carry a much higher risk of developing Stevens-Johnson syndrome or toxic epidermal necrolysis associated with the treatment of carbamazepine. So the difference between safety and efficacy is highlighted by that example, and that in that case, we're not trying to predict the response of the individual to carbamazepine or whether or not it would be effective in the treatment of either seizure disorders or bipolar disorder. The only reason to recommend genetic testing for this particular group is for safety reason, which is to decrease the risk of Stevens-Johnson syndrome. But good guesses. All right, going a little bit further, we need to understand that efficacy pharmacogenetics, as I mentioned before, refers to the prediction of a response to therapy as influenced by genetic variation. An example, I'm sorry, I'm saying the same thing that I've already, you have the slide showing what I've already mentioned. An example of safety pharmacogenetics is the FDA testing or FDA recommendation for genetic testing. Okay, so we're gonna break it down a little bit further and talk about genotype versus phenotype. Now, this is a very oversimplified definition. I'm not a geneticist, and I'm going to offend someone that likely has more nuanced knowledge about what this means. But I think, in general terms, a good broad explanation of genotype versus phenotype is that genotype refers normally to your genetic inheritance. So that would be the quote unquote nature part of the equation. And from a genotype perspective, we do see genetic polymorphisms, which are variations in specific DNA sequencing that are present in different ethnic groups. And they affect drug metabolizing status, can affect both pharmacokinetics and pharmacodynamics. As a reminder, again, pharmacokinetics are the actions of the drugs in the body over a period of time, including the absorption, distribution, transformation, and excretion, or metabolism and excretion. And pharmacodynamics is the effect of the drug on the organism, which I just mentioned. So, okay, so you got that in front of you. Okay, so gene expression is referred to as the phenotype. So once again, the genetic inheritance is the genotype. That would be the nature part of it, part of the equation. The nurture part of the equation, it would be considered the phenotype. Specifically with pharmacokinetics, we see some effects that are completely associated with gene expression, such as induction, which is the speeding up of metabolism, and can be produced by drugs such as barbiturates and anticonvulsants, alcohol, smoking, and diet dietary factors, which we'll talk about, and inhibition, which is the slowing of metabolism, and can also be produced by drugs, alcohol, disease states such as cirrhosis of the liver, and also by the interaction of drugs. So drug to drug interaction can certainly cause slowing down of the metabolism. Um, and pharmacodynamics, from a phenotype perspective, we see effects on albumin and receptors, up and down regulation of specific receptors that could be important. So I think I already mentioned pharmacogenetics seeks to individualize treatment, but a definition that you see in front of you is that is a study of the role of inherited and acquired genetic variation. So inherited genotype, acquired would be phenotype in drug response. And one other example that you see there is, the FDA revised the label on warfarin, which is a blood thinner, as you guys are probably aware, in February 2010, providing genotype-specific ranges of doses and suggesting that genotypes be taken into consideration when the drug is prescribed. Yet another example of safety pharmacogenomics. And the explanation for that is there. Let's see. And what you could see at the bottom is the clinical adoption of genotype-guided administration of warfarin has been slow, even though the evidence supporting such adoption is similar to the evidence supporting currently used clinical variables such as age, drug interactions, and ancestral origin. And I would argue that this is yes. So in this case, this is an example of both safety and efficacy. The ranges that are supported by genotyping are meant to both eliminate or decrease the potential adverse effects of the use of warfarin, as well as to increase the efficacy, increase efficacy based on genetic information. Okay. As far as environmental factors, here's uh, uh, here's a question, a hypothetical question. Does it matter if your patient had a cup of coffee, a martini, a carafe of wine, or grapefruit juice, and a charbroiled hamburger, Brussels sprouts, or a cigarette for lunch, or maybe all of the above? This is where we see those phenotyping influence or phenotype influence or environmental influence on gene expression in pharmacokinetics and pharmacodynamics. So as you could see clearly, flavonoids in soy and red wine can create an inhibition in the 1A1, 1A2, 2E1, and 3A4 CYP450s. Fruits, specifically grapefruit juice, as you have learned in other classes, are a 3A4 inhibitor. Cruciferous vegetables, including broccoli, sprouts, cabbage, are 1A2 inductors. Charbroiled beef also produces 1A2 induction, as does caffeine, especially significant amounts of caffeine. Smoking has the same effect, and alcohol results in 2E1 induction. And so is it important to assess the dietary habits and potentially changes in habits in your patients? I'm sure you've learned in other classes that if you have a patient who is a chronic smoker, 1 pack a day or higher, use or vaping high amounts of nicotine, that all of a sudden quitting, you want to think about how that decrease in the access and availability of nicotine is going to potentially affect their response to a medication that they're currently on or that you could be prescribing for them internally. So once again, want to emphasize the interplay between diet, your genetic constitution and things like dietary habits. As I mentioned before, dietary habits, such as the one that I listed in my previous slide, can change the body's ability to absorb, distribute, and metabolize medications. A high protein diet, for example, has been shown to enhance drug metabolism through increased oxidation and conjugation. And Asians and Africans exposed to a Western diet and environment do not exhibit the same sensitivity to psychotropics as those living in their home countries. So you can imagine again, once again, just like the smoker, the example of the chronic smoker, somebody who is, changing dietary habits, such as, becoming vegetarian or vegan, I have, changes in the effects that of the medications that they currently take. This is something you might have seen in other classes. I just want to highlight the predicted response to increased consumption of grapefruit juice. And, I don't know if you guys know too many people who will consume 5 glasses or 3 daily administrations of grapefruit. I suppose in South Florida, there's quite a few. And I have seen that to be quite representative. But even 1 glass of grapefruit juice can significantly impact the response in of or the absorption of certain drugs. So what you see in the lower lane here with the solid dots is consumption of water, with the white circle or the open circle indicating a consumption of 1 glass of grapefruit juice, and the triangle indicating 5 days and 3 daily administrations of grapefruit as they relate to felodipine oral availability in humans, by decreasing CYP3A4, CYP3A protein expression. So just in a few days, that availability is sharply increased by the addition of another, by the addition of 3A4, the induction, or protein expression associated with 3A4. Okay, sorry. Here's some other environmental factors that you need to be aware of. Once again, we talked about herbal remedies, natural substances, and we're going to talk about their use in some of the, among the ethnic minority groups that we discuss tomorrow. But you should know and have this, potentially as a reference, that things like nutmeg can be a 1A1 inducer. Eucalyptus, ginkgo, ginseng, and St. John's wort. That's that abbreviation right there in the second column. Can be 1A2 inhibitors. As you know, St. John's wort is commonly used or can be used over the counter for the treatment of depression and other mental conditions. And so you need to be aware when your patients are combining St. John's wort potentially with other medications that could be processed by the 1A2. Licorice is an inhibitor in the 2B6. And again, you could see some of the other examples for yourself, but, just want you to be aware and pay close attention to, clients that engage in high dietary intake, and or just supplementation with things like kava, or ginkgo, ginseng, and other so-called natural, or herbal products like echinacea. Let's see what else we got. Valerian, garlic, and vitamin E. All right. So we're going to break down a little bit what those polymorphisms that we talked about, the DNA sequence variations, mean in terms of the metabolism of drugs, in a little bit more detail. But again, this should be a review from other things that you have seen in the past. I'm kind of a visual person, so I'm going to show you some pictures that hopefully will help you to not just grasp but reinforce these concepts and think about how they may apply to populations that are genetically different. So poor metabolizer, by definition, is somebody who is unable to produce the CYP enzyme or has only one functioning allele or variant alleles, and therefore has less enzymatic activity. And what you would see from a poor metabolizer is either slow or no drug metabolism and high plasma levels at normal dose. So this is a person who's going to develop very high or significant side effects to even the smallest dose of the drug, because they have very little enzymatic activity and very or poor ability to metabolize the drug and ultimately eliminate it. Intermediate metabolizers have two deficient alleles, or one deficient and one non-functional allele. And what you would see with the intermediate metabolizer, kind of like with a poor metabolizer, but to a lesser degree, is increased plasma levels at a normal dose. A normal, quote unquote, or extensive metabolizer is someone who has two normally functioning alleles, and would have the expected response to standard dose. So that's pretty self-explanatory. And last but not least, the fast or ultra rapid metabolizers, also known as in some textbooks, have three or more functioning alleles. And therefore, as a result, they would show lower drug plasma concentrations despite the therapeutic dose, and may show no drug response at ordinary dosage. So this would be the non-responder class. You either have to, hike up, jack up the dosage of the drug, or you may find that you may have to choose a drug with a different mechanism of action or a different that is metabolized by a different CYP system, because it doesn't necessarily follow that a poor metabolizer is a poor metabolizer in all of the CYP 450 enzymes. So to put that in a picture, what I want to show you here, let me make it a little bit bigger so you guys can capture that. As I mentioned before, if we go from, we're going to go from right to left. Poor metabolizer has either two non-functioning alleles or one functioning, low functioning allele and one, what do we call it? Variant allele. That would be the dotted lines over here. That makes a person a poor metabolizer. An intermediate metabolizer has two two deficient alleles, that would be the yellow, or one deficient and one non-functional allele, and that turns them into an intermediate metabolizer. An extensive or normal metabolizer would either have two functioning alleles or one functioning and one deficient, and that would be the majority of the population. You see the numbers picture here. The number of the people figures represent the number of people who fall into one category. Allegedly, this is a graph from a pharmaceutical company, so don't take anything as gospel here. By the way, one thing I failed to say at the beginning of the presentation is I have no financial conflicts and no allegiance or alliance to any pharmaceutical companies. I'm an equal opportunity criticizer. Or a skeptic, I should say, not necessarily a criticizer. That's not even a word. All right, and then the ultra rapid metabolizer has either three functional alleles or more gene copies, and that turns their metabolism into super fast. And so what you see, and if you look at the bottom again from right to left, is the different dosing of a standard medication, whatever the medication may be. This is not one medication in particular, but just meant to be used as an example, that might be needed in order to achieve the same plasma level. So poor metabolizer might need 10 milligrams an intermediate or extensive, quote unquote, normal metabolizer might need somewhere around 100 milligrams, and an ultra rapid metabolizer might need 500 milligrams, so 50 times as much as the drug dose needed for a poor metabolizer. So, you can imagine that genetic polymorphisms, if this was a real drug, can, and you have um, an ethnic or minority group that has a tendency to be ultra rapid metabolizer, they could be seen as drug seeking simply because they don't process. They metabolize the drug so very quickly that they gain almost no effect from it. Or if the group is comprised or has a high number of her metabolizers, that may be seen as non-compliant or quote unquote or non-adherent, or difficult patients because they present with a higher number of side effects or problems associated with a very, very low dose of medications. Okay. I think this is a good stopping point before our next break. Again, just this should be a review, so hopefully presented in a way that makes it easier to digest what may seem like complex or complicated information. It's 3 minutes after 11 for those of you in the Pacific, so I'll see you in 10 minutes. During the rest of this section, right before lunch, we're going to keep on talking about genetic polymorphisms. We're going to talk specifically about how they may affect specific drugs, psychotropic drugs, to be more exact. And then, let's see. We are likely to have I'm going to give you an assignment to talk or to think about over lunch, to do over lunch, really. So there will be an extra 15 minutes or so for the lunch assignment. And then we'll resume. And again, most of today's class we'll be talking about, continue to talk about genetic polymorphisms, their effects on drugs, other factors that can affect pharmacokinetics and pharmacodynamics. And tomorrow we'll be talking about the major ethnic groups. So that's what we have. At this point, I know that Aiden wants to do attendance, so let's go ahead and do that right now.
I'll give it a few more seconds before closing the polls.
Sounds good.
I'm also chiming in, so it doesn't get marked as me being absent again. I get no more Nastograms. So I have a audio representation of my voice. So this is Eddie Waldrop.
Thank you. All right, looks like we have closed the poll for attendance, and we'll go ahead and continue. Okay, this is another graph that gives you a bit of information, not tons. And again, I have to advise you that this graph comes from advertisement with the, related to AmpliChip, which is a genetic testing mechanism from Roche, so one of pharmaceutical company. But according to this graph, which is specifically to the 2D6 system, you could see ranges of normal activity from 42 to 43% in Japan, 23% in China, 33 to 37% in Caucasian Europeans, 37 to 40% in Caucasian in the US, 29 to 34% in Black African, and 28 to 56% in Black African. I'm sorry, the previous one was Black American, so African American versus Africans. And this is just a one allele number one versus, all the other ones that you see listed there. The ones that are grayed out seem to be the most significant numbers. So just, again, take it for whatever it's worth. The 39 with regards to allele 10, where you got 39 to 41% of Japanese with reduced activity, otherwise known as either intermediate or poor metabolism. 50 to 70% of Chinese with regards to allele 17, 15 to 26% of African American, and 9 to 34% of Africans have reduced activity. And then finally, for 41, 20% of Caucasian European have reduced activity as well. So that's just, some additional information. Nothing you have to memorize specifically for our purposes. Here's some other information with regards to polymorphisms and the effects that you might see. Sorry, let me make this smaller so we could see this whole slide in one shot. There you go. 2D6 about which is responsible for the metabolism of about 20 to 30% of drugs, presents with 5 different types of polymorphisms. 2619 responsible for the metabolism of 5% of drugs, 2 different types of polymorphisms. And 3A4, which is the most significant one, which with regards to metabolism, is in terms of being responsible for the metabolism of 40 to 45 drugs. It's pretty rare to see genetic polymorphisms, but it is much more subject to environmental variations, and we'll talk about that. And then 1A2, also pretty small in comparison with regards to metabolism of most major drugs, and also presents with some polymorphisms. Again, just something to highlight, 3 or 4 changes are not inherited, but highly inducible. So behavior, and environmental factors are much more of an influence in 3A4 than they are in drugs like 2D6. Okay. Some other information with regards to incidence of polymorphisms. You could see a significant, so this abbreviation stands for poor metabolizer. Extensive metabolizer is SEM. I can't remember what the super extensive, actually. So super extensive, that would be the ultra rapid metabolizer. PM is poor metabolizer, and then you have intermediate and slow metabolizer is at SM. So you could see 33% of American Black are either intermediate or slow metabolizers of 2D6. Remember, some major 2D6 drugs include paroxetine or Prozac or fluoxetine. Again, a good number of African Americans would have trouble metabolizing drugs such as Paxil or Prozac. Let's see what else we want to highlight over here. 37% of Asians, same thing, slow or intermediate metabolizer. Intermediate metabolizers. 18% of Latinos. Yeah, and you could see some of the other ones for yourself. So when is drug metabolizing status clinically important? It's important, it's always important, but I think it's most critical, most important to understand it and to make sure that you are checking sources and checking this information when a drug is widely used. So again, the Paxils, the Prozac, the Zoloft, the drugs that are most commonly known, most commonly prescribed, we should be aware of their metabolizing impacts. When a drug has significant plasma concentration related side effects, so drugs like carbamazepine or valproic acid, and some of those plasma concentration related side effects. Some of the tricyclics have pretty significant plasma concentration side effects. When the therapeutic range is narrow, when there are few therapeutic alternatives, and when the drug does not work as intended or presents with significant side effects. As I mentioned before, if you have an individual who comes in and complains they've had no effect, to the highest range of the standard dose of the medication, then you should consider the possibility that the metabolizing status of that individual could be clinically important. Or if the person comes in reporting a significant number of side effects with just, the lowest dose, potentially available, that metabolizing status can be critically important as well. So you likely remember we talked about this case report in our gender class. This was the report of a child death that resulted when a breastfeeding mom was on codeine. The mother was determined to be an ultra rapid metabolizer for in the 2D6 specifically. And as a result, her ability to convert codeine to morphine was much more rapidly and complete than normal, quote unquote, metabolizers or extensive metabolizers. And of course, her child's was not. So, this in nursing moms, the metabolism resulting, in this case specifically, the metabolism, her high metabolism resulted in higher than expected serum level concentrations of morphine in the breast milk, which ultimately resulted in the baby's death. So again, it's really critical to understand a drug metabolizing status for individuals when any of these factors are present. Okay. So this is just another visual representation to help you understand calculation of genotype-based dose adjustments. Again, this is drug X, not any specific drug. Rebecca had a question. Do you test this with your patients? The simple answer is no. We have on occasion, I have on occasion requested metabolizing status testing on a patient. Normally as a result of somebody who's presented with very serious or significant side effects to more than one medication at a very low dose. So not routinely, not specific to any drugs. We don't do any type of genotyping prior to prescriptions, and we'll talk about that in a little bit or later. But if a person is showing up with significant, again, adverse effects to very, very small doses of drugs. And I mean things like, 25 milligrams of Zoloft or, 10 milligrams of Prozac. and this seems to be a repeated finding, then we will do some testing. Good question. Okay, so like I said, this is drug X, not any one specific drug. You could see the standard dose, it would be 2 tablets for a poor metabolizer, meaning one that has 2 non-functioning alleles, as you can see on the left-hand side. The standard dose may have to be reduced by 1 to 1 pill. And what you see in the bottom is the area under the curve. And if you remember, the area under the curve is the amount of drug in the bloodstream after a dose, much reduced, or much higher, I should say, for a slow or poor metabolizer, as you could see in this graph on the left, compare to a very, very low area under the curve for an ultra rapid metabolizer. The intermediate metabolizer might need 1.5 doses of the standard dose. Normal, of course, or extensive would be the 2 doses, and the ultra rapid might be 3 or more. Again, that's just a representation. But I wanted you to see, what I wanted you to take out of this graph is how sharply different the area under the curve could be depending on metabolizing status. So here's a sample drug response and how metabolizing status might affect it. You've got the proton pump inhibitors, or the PPIs, usually typically used for treating H. pylori infections and peptic ulcers. In poor metabolizers, 100% treatment rate for those who are homozygous, or meaning they have similar alleles or deficient alleles in CYP2C19. The 60% treatment rate in patients with heterozygous, meaning intermediate metabolizers, meaning they have one allele that is different from another, one fully functional and one poorly functioning or non-functional. 29 treatment rates for patients who have similar wild types of alleles. And I have to admit, I don't have a definition in my notes about what they mean by wild type. So if any of you have a good explanation of that, I am blanking out on it. And so, the report is that the higher accumulation of plasma omeprazole, PPI, in poor metabolizers results in a greater degree of gastric acid suppression. So this is an example of where actually poor metabolizer may have a more efficient, more efficacious therapeutic result compared to a rapid or even normal or extensive metabolizer, just based on the mechanism of action of the drug. Okay, so as I mentioned before, the CYP2D6 is very common in terms of the metabolism of several drugs, including including a lot of psychotropic medications, 25% of all medicines, and including a great many psychotropic medications, such as the ones that you see listed there. A lot of the TCAs have secondary metabolism that is also primed by the 2D6 and tertiary by the 3A4. So some of those, do have overlapping effects that could be both influenced by genetic polymorphisms and dietary or other environmental factors. So, main drugs that I think are important for you to know from here are, again, the most commonly used. So think about the most commonly used things like fluoxetine, haloperidol, nortriptyline, paroxetine, propranolol, risperidone, and venlafaxine, as well as some of the other ones on the left column, duloxetine as well. Some of the new and old antidepressants are also substrates or have 2D6 substrates like Trintellix, And others like Fanapt are also metabolized by the 2D6. With regards to Fanapt, yep, it's extensive. Trintellix is 2D6 is the primary metabolic enzyme involved in its metabolism, although it is also metabolized by 2A6, 2B6, 268 and 9, and 2619 to a lesser degree. I'm not sure exactly why this was out of order, other than the fact that we are now talking more specifically about the 2D6. But to go back to the case study that I mentioned before, we had the prodrug, which is codeine, metabolized by the CYP2D6, and it becomes morphine, which is the active ingredient. CYP2D6 poor metabolizers would lack analgesic response to codeine. So the effect for mom is she's an ultra rapid metabolizer. And that means that she converts the prodrug codeine into morphine much faster. Therefore, she would have a higher analgesic effect to codeine. This is the opposite of what we would expect from every other drug. So prodrugs are a little bit different in that a poor metabolizer would not be able to convert the prodrug into the active drug, and therefore would lack analgesic response or would lack the therapeutic response. Other drugs, what you might see, as I mentioned before, just looking at the graph, is that poor metabolizers would actually have a therapeutic response to a lower dose of the medication, but prodrugs work differently, and so you need to keep that in mind. And once again, I want you to be aware of how this may pan out in terms of perceptions of the patient and perceptions of the, or potentially prescriptive practices among otherwise uninformed, let's just put it that way, medical providers with different populations. So let's go back to this chart, because I think it's important to highlight who are the poor metabolizers in in the 2D6 system. As I mentioned before, 33% of American Black or African Americans, 37% of Asian Americans, and 18% of Hispanics. So it wouldn't be too far out of left field to think that, again, based on the provider's prescriptive practices, when these individuals, 1/3, to 1/5 to 1/3 of this population is not able to receive the analgesic effect of a drug like codeine, that they may be perceived as drug seeking, which may reinforce, potentially biases and stereotypes that the medical providers may have about this individuals. Okay. I'm going to move on to this 2C19 percentage of poor metabolizers on the 2C19 range from less than 3% of Caucasians and Mexican Americans, just to use some examples, to up to 25% of Japanese and 25% of African Americans. We do have some numbers that are more significant. So as you could see, let's see, in this studies, 18% of African Americans had little or no activity, meaning they were poor metabolizers. So in the 2/6/19, 20% of East Indians, 17.4% of Chinese, 21% of Japanese were poor metabolizers on the 2C19. This is the first number, 18.5. It does refer to population in the US versus the last three populations in their native country. Whereas, as you could see, the poor metabolizing status in Caucasian populations, the relative prevalence is much, much lower. Here are some of the commonly used drugs that are, or psychotropic drugs specifically, that are metabolized by the 2C19. with the help of others, as you could see, things like amitriptyline, citalopram. Uh, there's um, uh, other, commonly used medications such as sertraline, and you could see the asterisk for imipramine and sertraline is that they're also metabolized by other P450 enzymes, which is true of a lot of drugs, although many have a primary system that they respond to. Um, and then we do have some drugs that are inhibitors of this system, including fluoxetine, fluvoxamine, modafinil, topiramate, and paroxetine, and some inducers, such as the ones that you see listed in front of you. I'm just curious as I'm talking about this, have any of you or all of you heard about Hippocrates, and have you, and how often have you used it to reference information about the pharmacological or, pharmacokinetic um, properties of any of the medications that you deal with?
Yeah, yeah. I think it was last semester. I ended up downloading it and using it a few times, mainly for
Okay,
classes. It doesn't come up at work very often.
great. Okay. I highly recommend it. I don't, again, no financial ties, no financial specific financial interest or conflicts. But I just want to point out. Let me do citalopram as an example. It's a quick and easy reference, depending on where you work. If you're not tied to a computer, if if you're around, in hospitals or anything like that, you can have it on your phone. And if you pull up any drug, it'll give you dosing information, contraindications, black box warnings. But the pieces that I want you to be familiar with are pregnancy and lactation, which we talked about last week, in pharmacology. So when you click on the pharmacology tab, and I don't know if you're going to be able to see my phone, so I won't bother showing you. For citalopram, it tells you metabolism, and for this drug, it says liver extensively, CYP450, 2C19 is primary, 2D6, and 3A4 substrate. It tells you about excretion. So for example, it says urine, feces, half-life. Information about half-life is increased for elderly patients. It tells you the subclass of medications it belongs to, and it tells you its mechanism of action. And just as a way of information, for citalopram, specifically mechanism of action is limited to just saying selectively inhibit serotonin reuptake, which is kind of an easy cop out. But again, really good information at your fingertips that you could use almost any in any setting that you work in, so long as you have, um, cell service or Wi-Fi access. Um, Also, another feature that I find that I have found very helpful in my practice that I want to make sure you guys know about is that one of the sections that it has also is pill pictures. And so every now and then, when I have a patient that says, hey, I didn't get the right medication, or the pharmacy dispensed the wrong medication, or something along those lines, I can go into the app and I can sit with the patient and see, okay, let's look at the pill, see what it looks like, and what we may be looking at is another generic, a generic formulation that they're not used to. So, it helps to alleviate their fear that they may be taking the wrong medication, but it also helps us to clarify if they indeed received the wrong medication. So very, very helpful, and I'm glad to hear some of you guys have heard about it and are using it. But for all of you who are not, I just thought I'd put in a plug right here, because there is no way you're ever going to memorize this information. I'm saying all this with the understanding that you're going to need some ideas and some guidelines with regards to, inhibitors and inducers, and, commonly known and used medications that are metabolized by 2D6 versus 2C19. 3A4, et cetera, but without the ability to be able to memorize it all. This is a very good tool for you to be able to use and talk about with your patients. Okay, so along those lines, I want to emphasize something that you need to know about foot stomp. 2D6 and 2C19 are mostly under genetic control. So when we talk about genetic polymorphisms, you're mainly going to see them in these two systems. You can see very limited genetic variation in the 1A2 and 3A4 because they are mostly under environmental, including dietary control. So key information again, for those drugs that are metabolized primarily by 2D6 and 2C19, 2C19, you're going to worry about genetic polymorphisms. For those drugs that are primarily metabolized by 1A2 and 3A4, you're going to worry about, again, dietary factors, smoking cessation, and other environmental issues. Okay, let's do another poll before we break for lunch.
Doctor, I haven't had these numbers for morning polls. I had this for afternoon poll. I'm gonna launch them in the chat.
Oh, okay, no problem. Sorry about that. I think I'm ahead. Seems like I'm getting ahead, but it's okay. And as you're doing that, I'm going to stop sharing for a moment because I want to find the information that I need to give you for Okay, sorry, it took me a bit. So everybody got the name of the app. We're good. Okay, so question was providers are less likely to prescribe older medications or for more serious mental illness to minority groups. True or false? Um, let me make sure I got this. Actually, so I see a lot of false responses. So let's look at the questions again. Providers are less likely to to prescribe older medications for more serious mental illness to minority groups. And you're absolutely right. The answer is false. Providers are more likely to prescribe older medications um, to minority groups. Second question is a slow metabolizer of a drug is likely due to um, be unable to produce the enzyme or may have only one functioning allele or therefore have less enzyme activity, demonstrate higher plasma levels at standard dose, present with significant side effects at low doses, and the last one is all of the above. And, all things considered, yes, you guys are right. I think most people gave us the correct answer, which is all of the above. And I'm glad. Okay, I'm glad to see the information sticking pretty well. Okay, thank you all for participating. Are you all seeing my screen again?
Yes, sir.
Excellent. Thumbs up. Okay, sounds good. Thank you very much. All right, we'll just, um, I'm going to go ahead and paste our assignment here. It's an NPR report that talks about, in the context of talking about healthcare disparities, talks about the pain management and racial biases. I'm interested in your thoughts and questions about this report, and so we're not ready to break just yet, but I want to make sure that you have the link and that everybody's able to copy it or open it before the poll disappears or before the Zoom chat disappears after we break for lunch. Okay, we're going to talk about the 182 before. 182 next. I mean, again, we do with the 182, we see considerable polymorphisms, but no reliable interethnic differences. For example, 12 to 13% of Caucasians, Asians, and Africans are poor metabolizer, pretty similar rates across the board. But it's also very highly inducible by things like smoking, a high protein diet, charcoal broiled beef, industrial toxins, cruciferous vegetables, cabbage, sprouts, etc. And it's inhibited by corn and a diet high in carbohydrates. It's important to know that it's responsible for the partial metabolism of tertiary to secondary tricyclics, as well as haloperidol, clozapine, and olanzapine. And I'm guessing you have learned this in other classes, but one of the things you want to look at is significant overlap of a serious mental illness and consumption of nicotine. So when you talk about haloperidol, clozapine, and olanzapine, you're talking about treatment of serious and chronic mental illness, likely psychotic disorders or bipolar disorders with psychosis. And so high smoking or nicotine consumption rates is something that you have to worry about when prescribing this medications based on their interaction or their metabolism by the 1A2 system. Other drugs you need to know about, antidepressants such as amitriptyline, imipramine, and some of the more commonly used mirtazapine. or Remeron, and some of the antipsychotics I've already mentioned before. Other drugs that are much more commonly used, so not necessarily psychotropics, drugs like acetaminophen, caffeine, melatonin, naproxen, zolmitriptan, and zolpidem or Ambien. And we have, we do with the 2C19, inhibitors and inducers. And I've already talked about some of those in previous slides. Important to highlight here, this is CBC is carbamazepine. And so, just highlighting the fact that carbamazepine is an inducer. And you guys have probably heard an inducer of its own metabolism by several mechanisms, including the 1A2. So one critical exception is the CYP3A4. Again, the good numbers say up to 60% of all pharmaceuticals are metabolized by the CYP3A4. I think a previous slide said 40 to 45. It is really closer to 60 in this day and age. Is not subject to genetic polymorphisms to speak of, but it's readily inducible by drugs, including rifampin and carbamazepine. That's another, this is another system by which carbamazepine induces its own metabolism. It's also inhibited by drugs, by foods, including foods with tyramine, such as soy and red wine. So, consider your client's cultural dietary habits when you're, considering their use of a drug that is primarily metabolized by the 3A4. And here's some examples of those. As far as the antidepressants, some that are commonly used, like sertraline and venlafaxine. A newer one, vilazodone or Vibrate, extensively or primary substrate in the 3A4, sedative hypnotics, again, some that are pretty commonly used, including clonazepam, alprazolam, and zolpidem, and other medications, including some of the mood stabilizers and the antipsychotics. Let's see. Vidzima is also, I don't know why I didn't put it on the slides. I apologize for that. Oh, it's right there. Sorry. Levomilnacipram. It's not a name that I like to pronounce, but Vidzima, one of the newer antidepressants, it's also primarily metabolized by 3A4. Now, briefly, just want to emphasize that metabolism also occurs through phase 2. And if you, this is not intended to be a full review of phase 2 metabolism, so I'm just going to briefly cover the next couple of slides. But I just want to make sure that to highlight that there are also genetic polymorphisms or genetic variations with regards to systems that contribute to phase 2 metabolism. So glucuronidation is an example of that. A phase 2 metabolic process. It's a common pathway in the formation of hydrophilic drug metabolized. And there's been at least 33 families of UGTs that have been found. They have a nomenclature which is similar to the cytochrome P450 system. The ones that are most important for you to be aware of with regards to the metabolism of drugs are the 1 and 2, so UGT1 and UGT2 subfamilies. In human, they're most important in human drugs. And they too have, as I mentioned before, polymorphisms and show extensive variability across ethnic groups. However, there's not been enough attention, not enough studies that show what that clinical significance of these variations may be. So you're not going to see a lot of information in future slides or, potentially in some of your textbooks about what this, a variability across ethnic groups and the UGT systems would translate into, into clinical practice. But it is important to know that UGT metabolism is important for the primary and secondary and tertiary amines. The clozapine, olanzapine, and asenapine or Saffras, and for some benzodiazepines and some of the mood stabilizers as well. So it's complicated, and again, the bottom line is that we may have information that points us in one way or another with regards to metabolic status, but that is only one part of the picture. As we reconvene after lunch, you're going to find that it's that there are compensatory mechanisms, that there's additional factors that we may need to take into account. We'll be talking about the role of genetic testing and whether that's useful or maybe not as useful as we would like it to be or believe it to be, and so on and so forth. So with that, I know we're moving relatively quickly with regards to the slides today, but trust me, we're gonna, again, this class is not as jam-packed with information. We're gonna have some case studies and other experiences to discuss, including your homework assignments. So can I get a confirmation from everybody that you were able to open the link that I sent in the text box? Excellent.
Dr. I also added that to the Moodle.
Oh, great. Thank you. Thank you so much. Okay. Well, it's 12 o'clock in the Pacific. So let's go ahead and break for lunch. I'm going to give you an extra 15 minutes so you have the opportunity to listen to the report. And I welcome you to come back with comments, questions, concerns, ideas, thoughts that you get from this assignment. Have a good lunch, everybody, and I'll see you in an hour and 15 minutes.